Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Paige Kalika. She's a pediatric neurologist, and today's Kevin MD article is Learning the Language of Medicine from Student to Fluent Physician. Paige, welcome to the show.
Thank you so much for having me. I really love your website, the articles, everything. It's a pleasure to be here.
Well, thank you so much for writing and for coming on. Now, for those who don't know you, just to share a little bit about yourself and then talk about the article that you wrote on Kevin MD.
Oh, I'm a pediatric neurologist, which means I see babies, children, adolescents for any disorders of the nervous system, headache, epilepsy, developmental delay, autism, ADHD, all these things. And I'm an academic physician, which means I work at a med school. I work with med students, residents, fellows. So I work with a lot of trainees, a lot of learners. And as I was seeing all my patients and as I was working with my learners, I realized one of the biggest problems that everyone had was talking to patients, not being empathetic or being kind or bedside manner. Those are different things which we also need to learn. But our patients and their patients' families weren't understanding what we were saying because medicine is a language. I realized this, and this is something that occurred to me as I was driving on my commute, which was at that point pretty lousy. And I had a lot of time to formulate this idea that we learn medicine in much the same way as we learn a second language. We go to school. We learn the basics. We learn the vocabulary. And the vocabulary is, of course, it's the words. It's all of our fancy technical words, but it's also the concepts. That's the foundation. And we learn our physiology, pharmacology, microbiology, biochemistry, and we build on that. We're building on the concepts and we're making these words into phrases and phrases into sentences and sentences into paragraphs. And we're building this whole language in our mind and it all makes sense. So I like to joke, and I'm sure I'm not the only one who jokes about this, the real Krebs cycle is learning the Krebs cycle, forgetting it, learning it again, forgetting it again. But the thing is, we do learn it, and even though we have to relearn it every time to remember the details, it's still in there and we built on it and we understand everything that was built on that foundation. And that's what we carry with us when we talk to our trainees, when we talk to our patients and their families. And our trainees are learning the language also, so we're teaching it to them. But our families don't have that background for the most part. And when we start rattling off our jargon, they get lost, they get confused. Sometimes they'll ask us questions. Other times they just shut down and figure that they'll Google it later, ask their friends, or just give up. So one of the most important things we can do as clinicians is to take the time to translate back from medical jargon into plain language. I say plain English, but I work in South Florida, so plain Spanish, plain Portuguese, whatever language your patients are speaking, we have to be able to communicate these very complex concepts in clear language. One of the things that kind of prompted me on this was back when I was very early in my career. I saw a very cute little girl for evaluation of epilepsy for seizures. So, okay, not a big deal. I know how to do that. And so I explained the diagnosis. I explained, oh, we're going to do this test and that test. And we're going to start this medicine. We're going to start Keppra, levetiracetam. And the father asked me a very simple question. What does the medicine do? And I was taken aback. You really want to know the mechanism of action of Keppra? Okay. And I did my best to explain it. And he listened. He was very kind about it. I could tell that it was going over his head. And to be fair, it had been a little while since I'd taken my board, so I probably was not explaining it as well as I could. And at the very end, he just smiled and said, yeah, I once spoke to a doctor who said that the mark of someone who truly understood was someone who could explain it to a layman. And that really made an impact because I realized he didn't want to know what the Keppra was actually doing. He wanted to understand what it meant, what it was going to do for what it was doing for his daughter. And that's not the same thing as understanding what the medicine is doing in her body. He wanted to understand the concept behind it. The medicine is protecting her from seizures. I like to tell parents now that I had that experience, I'll tell parents, okay, the medicine works like an umbrella. And I will say, this is not how it works in real life. There are no seizure waves raining down on you from above, but imagine seizure waves raining down on your child from above. If they hit your child, they might have a seizure. So you hold up your umbrella. The medicine is your seizure umbrella. and the medicine protects you from the seizure waves. So as long as you're taking the medicine, it's harder for the seizure waves to get through and make a seizure happen. If you stop taking the medicine, that puts holes in the umbrella. The seizure waves can get through. But sometimes, even when you're doing things perfectly, you take the medicine exactly the way you're supposed to, sometimes the rain gets through anyway. We've all been out in big
Hmm.
storms where the rain is splashing up on, and getting our feet wet no matter what we do. And that happens sometimes, but we're still better off with that umbrella than without it. And people seem to appreciate that because they want to know what the medicine is doing for them on that kind of conceptual level. So I picked up a bunch of scripts that I use for my most common conditions, and that seems to help my families understand more about what's going on.
Now, how does it get back to you that patients in general aren't understanding a lot of what their clinical staff says? Do you get surveys, feedbacks? Like, how does that get back to you?
A lot of times they'll tell me themselves. A lot of times it's very flattering. Oh, I never understood this before I spoke to you. And which, of course, I love to hear that.
Hmm.
But a lot of times I see it when I'm with my trainees because I figure that the best way to learn is to do. So I'll try to model as much as I can. But then I'm like, okay, you talk to the families. I'm here. I'm here standing beside you. I'm supporting you. I will jump in if you need me, I promise. And I'll see them talking and I will see the expressions on their faces, on the families and the patients' faces kind of glazing over.
Hmm.
They get that look where I I've been on the other side of that look where, I'm in a complicated calculus class. I'm like, oh, I'm not sure about these variables. I'm not quite sure what's going on here. I don't know. I'm getting lost. And you can tell. And sometimes I'll give them some time, the trainees, some time to course correct, and other times I'll try to slide in. Other times, yes, we get feedback. We have our beloved Press Ganey scores,
Hmm.
which again, usually these days I'm very pleased and flattered to see that people are understanding me. But, when I see other people sharing them, it seems to be a common complaint because it's so easy for us as doctors, as clinicians, to slip into this language that we speak to each other because this is an efficient language. If I say, oh, I see non-specific flare hyperintensities on the MRI to another neurologist, they know what I'm talking about. But then I have to sit there and try to explain this to a parent. Like, what does that mean? That sounds terrible. No, 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 it's not that bad. But what does it mean? Like bright spots on the brain. Oh my God, bright spots. That's terrible. No, 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 really, it's non-specific. What does non-specific mean?
Hmm.
It doesn't really mean anything. It just means it's kind of there. It's probably not bad. So this language can be very, very intimidating. But for us, as fluent speakers, it's so easy for us. It's so clear that it's hard for us to remember what's, normal language, what's, common parlance and what isn't.
Now, what are some of the root causes why you think that there's that communication disconnect? Is it just simply a lack of training? Is it, as my daughters say, a skill issue? Is it a time issue, time pressure? What are some of the reasons why you think that there's that disconnect?
I think it's a bit of everything. I mean, there's always going to be some people who like to sound smart.
Hmm.
Hopefully, not too many. Hopefully, we're learning better than that. But of course, there's always going to be someone. But yeah, we're in a rush, we're hurrying, and we slip into the language that it's easiest for it to explain this in. But I think a lot of it's a skill issue because we're not taught this.
Mm.
We're taught medicine, we're taught the concepts, we're taught how to treat. We're even getting better at learning bedside manner. But this is not exactly the same as bedside manner, although of course they're related. I was thinking about it recently and I decided to myself that bedside manner is making sure that the patient feels heard. And this kind of effective communication is making sure that the patient hears you. And there's a lot of back and forth because, again, sometimes we'll be speaking with patients with a strong medical or scientific background. And I'm like, oh, okay, we can speak a little more medical now, right? But even so, we still need to be careful because when we're talking about our own medical issues or our children's medical issues, even when it's in our field, it's hard because we're not processing as a clinician. We're processing as a patient. We're processing as a parent.
Hmm.
And that's a very different thing. We can't, this is why we don't treat our own family members, or we shouldn't treat our own family members, because we can't relate to them on that purely clinical level that we need to practice medicine in the best way.
So, what are some of the tips that you give the trainees when it comes to communicating medicine in plain language?
The most important one is stop and listen because we tend to go off on our long tangents because it's efficient.
Hmm.
Because here, let me pack all of the information into one run on sentence and that'll be it. No, speak slowly, speak clearly, speak in shorter sentences, give them time to think about it, respond. If you're going to use jargon, and what I tell the parents is, here, I'm going to say this in medical first, and then I'm going to translate it for you. Because that way, if they happen to take a look at that scary MRI report later, they're not going to freak out that this included scary language that they didn't hear before. They'll say, oh, she said that word, she explained it. I may not quite remember what it means, but I remember it wasn't that bad. So explain. Do your best to break this down into, common language and ask for feedback. Don't be afraid to ask for feedback. Do you understand me? I know that we talked a lot. I know that this was kind of complicated and there's a lot going on. What else do you need me to explain? And then I'll also tell my families, and I'll tell the trainees to do this. Let me write it down for you. Here, let me give you, I call them my cheat sheets. I have cheat sheets for a lot of things. And like, here, read this later because I know as soon as you leave, half of this is going to fly out of your head. I know it happens to me. So these are the important points. This is what you need to do. If it is not clear, call me, send me a message through the patient portal. Everyone loves to message me through the patient portal. And we can always go through it again if we need to. But when it's written down for them, it seems to help also because it prompts them. And then I'm sure everyone goes and Googles things and then they find scary things and they come to me with the scary things. But I tell them, if you find something scary, tell me. I promise if we're going to panic, we will panic together, but we're not going to panic because we're going to have a plan and we're going to go through it.
Now, it sounds like this is a pretty important skill that needs to be taught better in medical school and residency. And obviously, you work in an academic medical center. So, are these students and residents, are they really not formally taught how to communicate in plain language? Is this something that they just need to learn based on the models that they see in their clinical rotations?
I think things are changing. I know that my medical school has changed the curriculum a few years back to be much more integrated, much more holistic. The medical students are going out into the clinical world much earlier. I'm getting these medical students when they're still, well, babies. No, they're
Yeah,
still what I used to call an MS1 or an MS2. Before, I didn't see med students until they were MS3s or possibly even MS4s.
yeah,
Now,
yeah.
these brand new medical students are out there seeing patients. So it sounds like there's a big push to have them, out there working with patients much earlier. And I think that's going to help because when we spend those first 2 years locked in a classroom, you know, learning all of our language, learning our jargon, we forget, you know, we we have to relearn later how to speak to actual people. This way, if they're learning the jargon, they're learning the language as they're actually seeing patients and they're putting it into practice, I do think that's helping. And I think I'm seeing a shift in my med students. I think I am.
Now, what do you say to those busy clinicians? Everyone, of course, is time pressured in primary care. We have like 5 to 10 minutes to see patients, and sometimes communication is not at the top of our list of things to do. So, how do you advise those time pressured physicians to still communicate clearly despite everything else they have to do in that visit?
That is so hard. I tell everyone this is why I'm not doing primary care. I'm not smart enough to know everything. I don't know how to do everything, communicate everything, and how to boil one entire complex human being down into a 10-minute visit if you're
Mhm.
lucky, a 10-minute visit. So it's hard. I would say in your copious amounts of spare time, I know that doesn't exist, try to make your cheat sheets because I know my most common conditions. So I was able to take some time, write it down. And if you're in primary care and you know that you're going to be seeing everyone with diabetes, hypertension, hyperlipidemia, all these things over and over all day, take a few minutes, write it up just in, again, plain language. This is what you have. This is what's going on. These are the most common interventions. And And again, it's hard. I don't know how anyone fits all of this into a tiny little visit. I mean, I'm very spoiled. I usually have an hour for new patient visits. I realize what a luxury that is. But do your best to say, okay, this is the 30-second summary of what's going on. Here is what I have for you written down. Take a look at it. If you have questions, check back in with my office. Tell me what the questions are, and either I will address it, or hopefully, if you're someone with good support staff, you know, my team will, assist you with it. But I don't have a great answer otherwise, other than to say the system is very broken and it's very hard to provide appropriate care like this. I know everyone's out there doing their best, and I hope we see some positive change soon because we're all feeling very, very squeezed.
We're talking to Paige Kalika. She's a pediatric neurologist, and today's Kevin MD article is Learning the Language of Medicine from Student to Fluent Physician. Paige, let's end with some take-home messages they want to leave with the Kevin MD audience.
For clinicians, do your best. It's not going to be perfect, and that's okay. You're going to, over time, you'll figure out more effective ways to communicate. It's going to change over time. My communication strategy certainly has. I know that 10 years from now, I'm going to look back and I'm going to think, wow, I was not great then either. But, we're evolving, we're growing, and I think our patients appreciate it. So do your best with it. Don't beat yourself up, and always leave space with your patients and their families for them to ask questions, even if it's just, 30 seconds at the end of the visit. Try to give them that space because they'll remember. Even if they don't have a question, they'll appreciate that you gave them that space.
Paige, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thank you so much. It's a pleasure to be here.